this. All right. So let's kind of return back to the ventricle, and here's a summary chart looking at the different phases and the responsible ions, associated with each phase. And of course, based on the shape, we know this is ventricular muscle. I want the thing to go forward. Here we go. Okay. And the reason we talk about, or I remind you about the ventricular muscle, is because now we're going to look at the beta receptor again.
So bear the calcium channel blockers in mind. The beta blockers are another very handy drug, and like I said, you are going to hand these out. And I have heard from clinicians that you could almost be sued for not handing them out, at least in some situations, because they are generally safe and they have been proven to be effective. And that is a great combination for a class of drugs, okay? And they do so many things. They decrease the rate of supraventricular tachycardias because they slow phase 4 in all tissues, which exhibit automaticity, from the SA node to the Purkinje fibers, okay? So anytime you have an ectopic pacemaker, or anytime that you have some sort of a supraventricular tachycardia, perhaps due to the fact that your SA node is firing too quickly for some reason, a beta blocker can do wonders to slow that down, okay? Because it slows the rate of phase 4 depolarization, because if your beta adrenergic pathway ordinarily activates all type calcium channels and facilitates your pacemaker channels, then a beta blocker will prevent that, and it will slow that increase in phase 4, and it'll slow the heart rate, okay? So we increase the AV nodal delay, very handy with supraventricular tachycardias in particular, and I just explained why with calcium channel blockers, so that's very helpful, okay? You decrease triggered arrhythmias. Okay, this turns out it's largely due to the fact that you're preventing that activation of the L-type calcium channel. Your triggered activity, your EADs, your DADs tend to be associated with high catecholinergic activity, high sympathetic tone, stress, exercise, you know, things like that, all right? So a beta blocker can do very nice things to prevent anything that high catecholinergic activity tends to cause. And DADs and EADs, triggered activity, would fall into that class. So they're very good for that as well, okay? So this is a very handy class of drugs. And finally, they reduce oxygen demand in myocardial ischemia. I think that makes sense. Yes, you are decreasing the force of contraction, and in a heart that's already having a hard time generating the proper stroke volume, but you know, you don't want that tissue to degrade too quickly because it's not getting enough oxygen either. So this can have a beneficial effect in terms of decreasing oxygen consumption in ventricular tissue and myocardial ischemia. So this is something you can pull out of your tool belt for an awful lot of things. It's really safe to give, generally speaking. And like I said, it's always helpful when the literature says, yes, this works, okay? And as it turns out, it does.
So just kind of a few things about beta blockers, and Dr. Shannon's right, they treat almost everything, right? So every pathophys lecture that we've talked about in terms of the heart, we've brought up the use of beta blockers, right? From, you know, hypertension, myocardial infarct, coronary artery disease, now anti-arrhythmias, and heart failure tomorrow, okay? And so we had really focused on the mechanism of action here in terms of what the beta receptor does upon stimulation and basically opening up calcium storage inside the cardiac myocyte. But I think maybe the nuance here is that, you know, perhaps you didn't realize that, you know, once this message had gotten inside the cell, that now different ions, different ionic pumps have been affected too. And so why do we say that, you know, post-MI, the patient must be on a beta blocker? We said that, you know, in terms of their survivability, we've got clinical data that backs up that beta blockers prevent recurrent myocardial infarct, okay, and stop sudden death that was associated with patients that actually survived a myocardial infarct. Well, the sudden death was really brought on by exacerbations due to heart failure, which were driven mostly by large portions of ischemic tissue that was unresponsive to electrical stimuli, which produced arrhythmias. Okay, and so back in the day, if a patient survived a myocardial infarct, okay, the arrhythmia would manifest itself shortly thereafter. And so by putting a beta blocker on board, you're actually kind of preventing the pathogenesis of an arrhythmia to manifest itself, because you're basically altering the ability of this influx of calcium to control these ions as well. Okay? And so when you have an increased AV nodal delay because of excess amounts of norepinephrine and so forth, that can be the thing, one of the precipitating factors that actually can trigger some of these arrhythmias. So that's one of the other things that I just wanted to recur. And then again, this notion of reduced oxygen demand due to myocardial ischemia has been kind of the underlying theme for all of these pathogenesis discussions in terms of how the beta-1 receptor, if it's left open, can actually kind of produce a lot of these arrhythmias and diseases. Okay? And so, again, we're basically looking at the amount of calcium that's inside the cell. I wasn't wondering why I put this in here. And we're looking at the ventricular myocyte, especially. Okay, and so calcium plays a major component in terms of membrane potential, and beta blockers basically prevent that huge influx of calcium that's associated with norepinephrine binding to this receptor. So when you give a patient a beta blocker, obviously heart rate's going to be reduced. We're going to reduce the amount of intracellular calcium that's available within the myocardiac cell, and we're going to inhibit these after depolarizations. And that's going to be kind of the thing that's driving this mediated automaticity. So mechanism of action, what they do, they block the beta-1 receptor, but they also have what's called direct membrane stabilizing effects. So these are beta blockers that have some sodium channel blocking activity. And so I don't remember one of those Goodman and Gilman summary tables that I'd put up, I think maybe in the first heart lecture slide series, was, it had a whole list of beta blockers, and the first column was membrane stabilizing effects. And that's the ability of this beta blocker molecule to inhibit sodium channel activity through beta-1 inhibition. So this is kind of a downstream kind of effect. Other nuances to beta-1 receptor antagonists include ones that have intrinsic sympathomimetic activity, deemed ISA. So these are beta blockers that have partial agonist activity. Okay, so again, and I still get questions about this, even from third year and fourth year medical students. What the hell is a partial agonist? All right, go back to real fundamental pharmacology. Okay, an antagonist produces zero physiologic activity, right? An agonist produces a magnitude-fold higher increase in physiologic activity. So let's just say, to make it simple, antagonists produce an output of 0. Agonists produce an output of 10. Partial agonists, or drugs that have intrinsic sympathomimetic activity, have an output of 4 or 6. Okay? So one could argue, well, how did they make partial agonist drugs? Well, they tried to make a beta blocker, and it was crappy. All right? So it didn't annihilate the beta-1 system. Okay? It didn't stimulate the beta-1 system. Okay? It was a mediocre antagonist. And so we found clinical use for these. We'll discuss the mediocre antagonists tomorrow when we talk about heart failure, because that's actually where they start to kind of demonstrate some of those effects. Of course, on the electrical side, beta blockers will prolong the cardiac action potential. That's kind of like the basis for this lecture. You've heard of some of these already. Esmolol. What do you guys know about esmolol at this point? Short acting, only given IV. Guess when we're going to use it? Today. Okay, in the anti-arrhythmic patient. Sotalol we'd already talked about. Okay, so this is both a beta blocker and a potassium channel blocker. Okay, and then ace-butylol and propranolol, of course, are the more, the grandfather kind of beta blocking agents that are neither specific for beta-1 or beta-2, but still share some of these mechanistic approaches that we're going to use to target this system. All right. And so this is kind of a nice summary table, because now we're looking at whether or not this beta receptor and blocker, quote unquote, is indeed beta-1 selective. And which ones are beta-1 selective? Acebutolol to some degree. The major beta-1 selective drugs, and you know these by now, are atenolol, metoprolol, and esmolol. Okay, and so atenolol and metoprolol are essentially more or less the same indications. Esmolol is one that's short-acting, okay, very weakly soluble, and its half-life is 9 minutes. Okay, so you don't see patients on esmolol for 20 days or 20 years. You'll see them on it for maybe 2 or 3 days while we stabilize them. And this is, again, during the acute MI phases when you really want to have tight control of that beta-1 receptor. All right? You don't want some of these arrhythmias to manifest themselves. This class 1, what does that refer to? Well, this refers to the beta blocker to have membrane stabilizing activity. So what they're really comparing is this beta blocker to act like a sodium channel blocker. That's what this class 1 indication means. So you could just write that on there. So which one of these beta blockers acts like a sodium channel blocker? Acebutolol, carbidiol, indolol, and propranolol. Okay. Which of these beta-1 antagonists have intrinsic sympathomimetic activity? Which ones can act like a partial agonist? Okay. Acebutolol, labetalol, and pindolol. Okay. So as you kind of go through this, this continuum, and really it's a continuum. These are not separate diseases in the cardiac unit. It's a continuum. A patient can walk in with hypertension in the emergency room. They can have a heart attack in the emergency room, and they can leave with heart failure. And during that period, they may have had an arrhythmia for maybe 3 hours. Okay? So this could all physically be one patient over a span of 50 hours.